So let's talk about a very fatal infection, rabies. Rabies is a rapidly progressive acute infectious disease of the CNS in humans and animals that is caused by infection rabies virus. Rabies are encephalitic, and paralytic forms that ultimately progress to death. Rabies is an infectious disease that is 100% fatal. Rabies virus is a member of family Rhabdoviridae, two genera in this family, that is Lissa virus and vesiculovirus. This is a single-stranded RNA virus that is a non-segmented negative sense, that is an antisense virus. Rabies is a zoonotic infection that occurs in a variety of mammals throughout the world except in Antarctica and some islands. Rabies virus is transmitted to humans by the bite of an infected animal. Worldwide, endemic canine rabies is estimated to cause 59,000 human deaths annually. Most of the deaths occur in Asia and Africa, with rural population and children most frequently affected. Worldwide, most human rabies is transmitted from dogs. In North America, human rabies is usually associated with transmission from bats. Transmission has resulted from corneal transplantation and also from solid organ transplantation and a vascular conduit for a liver transplant from undiagnosed donors. Human-to-human transmission is extremely rare. Incubation period is usually 20 to 90 days. And during most of the incubation period, rabies virus is present at or close to the site of inoculation. In muscles, the virus is bind to nicotinic acetylcholine receptors on postsynaptic membranes at neuromuscular junctions, but the exact details of viral entry into the skin and subcutaneous tissues have not been clarified. Rabies virus spreads centripetally, very important. Once again, there is a marker. Yeah, it spreads centripetally along with peripheral nerves towards the spinal cord and or brainstem, and via retrograde fast axonal transport at the rate of approximately 250 mm per day. Once the virus enters the CNS, it rapidly disseminates to other regions of the CNS via fast axonal transport. After CNS infection becomes established, there is a spread along sensory and autonomic nerves to the other tissues, including salivary glands, heart, adrenal glands, and skin. Rabies virus replicates in the acinar cells of the salivary glands and is secreted in the saliva of rabid animals that serve as vectors for the disease. The most characteristic finding in rabies is a Negri body. Negri bodies are eosinophilic cytoplasmic inclusions in the brain neurons that are composed of rabies virus proteins and viral RNA. Coming to the clinical stages of rabies, incubation period is 20 to 90 days. Prodromal phase lasts in 2 to 10 days. That is fever, malaise, anorexia, nausea, vomiting, paresthesia, pain, and pruritus at the site. Acute neurological state, encephalitic, that is around 80%. In 2 to 7 days, there is anxiety, agitation, hyperactivity, bizarre behavior, hallucinations, autonomic dysfunction, and hydrophobia. Paralytic, it is around 2 to 10 days. There is flaccid paralysis in limbs progressing to quadriparesis with facial paralysis. Coma and death in 0 to 14 days. So, rabies virus specific antibodies. In the previously unimmunized patients, serum neutralizing antibodies to rabies virus are diagnostic. Antibodies may be detected within a few days after the onset of symptoms, but some patients die without detectable antibodies. RT-PCR amplification. Detection of rabies virus RNA by RT-PCR is highly sensitive and specific. This technique can detect the virus in fresh saliva samples, skin biopsy specimens, CSF, and brain tissues. Bite wounds should not be immediately sutured to prevent additional trauma, which may help spread the virus into the deeper tissues. If suturing is necessary, it should be done at 24 to 48 hours later, applying minimum possible stitches under the cover of rabies immunoglobulin locally. Post-exposure prophylaxis if required, administration of rabies immunoglobulin in case of severe exposure. Post-exposure prophylaxis is applicable as soon as possible. Vaccines with a potency of at least 2.5 international units per single immunizing intramuscular dose according to one of the following schedules. So now, did the animal bite the patient, or did saliva contaminate a scratch, abrasion, open wound or mucous membrane? If the answer is no, rabies prophylaxis is not required. If rabies yes, is rabies known or suspected to be present in the species or in the geographic area? No, then no rabies prophylaxis is required. Was the animal captured? No. Rabies immunoglobulin and vaccine? Yes. Was the animal a normally behaving into cat or ferret? Yes. Does the animal become ill under the observation over the next 10 days? No. Then no post-exposure prophylaxis is required. Was the animal a normally behaving cat, dog or ferret? No. Then does laboratory examination of the brain by fluorescent antibody staining confirm rabies? Yes. The rabies immunoglobulin and vaccine. The categories of post-exposure prophylaxis. Category 1 is touching or feeding animal, licks on intact skin. Post-exposure prophylaxis is not required. Category 2 is nibbling of uncovered skin, minor scratches or abrasions without bleeding. Without bleeding is very important. Immediate vaccination and local treatment of the wound. Category 3, single or multiple transdermal bites or scratches, licks on broken skin, contamination of mucous membrane with saliva from licks, contacts with bats, immediate vaccination and administration of rabies immunoglobulin, local treatment of the wound is required. So, intramuscular schedule is the SN regimen. One dose on day 0, 3, 7, 14 and 28. All intramuscular injections to be given into deltoid region or anterolateral aspect of thigh muscle in small children. 2-1-1 regimen, 2 doses on day 0, one on the deltoid of right arm and other in the deltoid region of the left one. 1 dose on the deltoid region on day 7 and 1 on 21. That is 2-1-1 regimen. This regimen is particularly recommended when no immunoglobulin is required. That is when contact consists of nibbling of uncovered skin, minor scratches or abrasion without bleeding, or licks on broken skin. Coming to the intradermal schedules, 2 sites of intradermal method, that is 222-011 and 222-02 for use of purified varicocele vaccine, purified primary chick embryo vaccine and human diploid cell vaccine at 0.1 ml per intradermal injection site. On days 0, 3, 7, 0.1 ml at each 2 sites intradermally on upper arm over each deltoid. Day 28, 90, and 28 and 90 it is 0.1 ml at one site on upper arm. The single dose of vaccine given on day 90 of the original Thai Red Cross regimen can be replaced if 2 doses of vaccine are given on day 28. Rabies immunoglobulin for passive immunization. Rabies immunoglobulin for passive immunization is administered only once, preferred at or as soon as possible after the initiation of post-exposure vaccination. The dose of rabies immunoglobulin is 20 international units per kg body weight. For equine immunoglobulin and fragmented antibody products, it is 40 international units per kg body weight. All of the rabies immunoglobulin should be administered as much as anatomically possible into or around the wound sites. The remaining immunoglobulin, if any, should be injected intramuscularly at the site distant from the vaccine administration. Post-exposure prophylaxis for previously vaccinated individuals. For rabies exposed patients who can document previous complete pre-exposure vaccination or complete post-exposure prophylaxis, 1 dose delivered intramuscularly or intradermally on day 0 and 3 is sufficient.